So I'll just, before I start, summarize it. Endoflip is useful only for the gastro-oesophageal junction in the esophagus, and it is only useful to test whether it opens or not. That's the only usefulness it has.
Whether
it opens or not, and how much it opens in response to pressure. It is not useful for motility in my practice because patients have to be awake, and no patients I've seen tolerate Endoflip very well when they're awake. The patient cannot participate, therefore, in the procedure. So it's not like manometry, where you have the patient participating, swallowing things, eating things. I never heard of the ESDE before that day, but that is a group of esophageal experts, maybe you've heard of it, who gather in a different European city every 2 years to talk about diseases of the esophagus. And then this year was in Leuven in Belgium. Discuss new definitions of the gastro-oesophageal junction, discuss the role of a functional imaging probe in different situations, make some cases, and talk about, I won't talk about pH-metry. There is a new consensus document on the gastro-oesophageal junction, whereas previously I don't think we had a very structured way of defining the gastro-oesophageal junction as endoscopists. Now we do. We previously used proximal end of the gastric folds to define where the gastro-oesophageal junction started. And now the recommendation is that we use the distal end of the palisade vessels to do so. Why is that? It's something to do with the insufflation, because everybody knows that the more you insufflate, the more that it retracts down and flattens out. And you can probably define the position of the gastro-oesophageal junction in 20 different ways in one patient just by using 20 different grades of insufflation. So that's why they recommended using this line rather than the top of the gastric folds. And you can see that a bit here. So here you see it not insufflated at all. Where is the top of the gastric folds? Is it here? Is it here? You know, right? Here it's a bit more inflated. Here it's a bit more inflated, and probably that there is now here. So actually, that's what we're talking about as the gastro-oesophageal junction, not this poorly defined area. That's important for lots of things, and we'll come back to it. The FLIP probe, functional luminal imaging probe, endoscopy, FLIP functional luminal imaging probe, is a catheter. It's not a dilatation balloon, so it's floppy. So how do you therefore interpret FLIP results? Well, this is your distensibility index. Indeed, as we said, under 2, definitely abnormal, 2 to 3 indeterminate, and over 3 normal. The diameter is also important because, as you saw, we discussed a case earlier where the diameter was maybe 8 to 10. Maybe that is abnormal in that situation, but necessarily, if it doesn't match with the distensibility index, then potentially it's not. But an esophagus, as we all know, of probably over 15 is acceptable for patients to swallow, and they came out with over 18 as their diameter for a normal FLIP measurement of the esophagus. And the contractility, I'm just not, I don't believe that FLIP is useful for that at all. This is a patient who had a POEM with an Eckhart score of 8, symptoms for 5 years, IRP at manometry of 35, and endoflip distensibility pre 0.7. Right, so this is the image pre. You can see this is the gastro-oesophageal junction. You can see that the diameter at the gastro-oesophageal junction is 4.7 millimeters only. If we go back to our chart before, that's clearly abnormal. It's under the numbers which were recommended, certainly nowhere near 18. Whereas you can see that the esophagus above is opening to 18, 19 sort of level. Distensibility is 0.7, so very much below the threshold of 2, which is considered abnormal, and with a decent balloon pressure here of 25. This is a patient who had a POEM with an Eckhart score of 8, symptoms for 5 years, IRP at manometry of 35, and endoflip distensibility pre 0.7. Right, so this is the image pre. You can see this is the gastro-oesophageal junction. You can see that the diameter at the gastro-esophageal junction is 4.7 millimeters only. If we go back to our chart before, that's clearly abnormal. It's under the numbers which were recommended, certainly nowhere near 18. Whereas you can see that the esophagus above is opening to 18, 19 sort of level. Distensibility is 0.7, so very much below the threshold of 2, which is considered abnormal, and with a decent balloon pressure here of 25. So this number, I mean, who cares? You're not doing endoflip, but that just means that you can rely on the result. Then after, so we have a distensibility of 3.2. So this was done pre-poem and then after the poem. You can see the diameter, which was previously 4.7, is now 8.1, and the distensibility is up at 3.2. So clearly and thing. Another pre-poem, 4.9 and 4.7 diameter with a distensibility of 1.2, and then afterwards a diameter of 11.7, and I don't think I've written the, oh yeah, here it is, the distensibility of 6.8 with a delta of 5.6. And if we just go back to that data from before, it's sitting in the range of acceptability after poem. This one isn't. So it'd be interesting to see. I don't remember and haven't looked, but it'd be interesting to see if that predicted whether that patient might come back. It's of course interesting to ask yourself the question, I did a complete myotomy and it's not enough. What should I then do? Make another tunnel and do another myotomy in another orientation? I don't know the answer to that. Motility we talked about. To conclude then about flip and achalasia, it's complementary and in some cases an alternative to HRM, especially where HRM does not give you the answer you're expecting. I think intraoperative flip is useful, and management of flip distensibility after doing anything to the LES can be helpful in terms of figuring out what to do. What about the future of flip? I don't think there's anything else here. So this is the final slide. A lot of people ask me why I'm using Endoflip. I hope I've justified to you why it's useful now. The thing is totally unuser friendly. I mean, who's ever seen a thing that looks like that? I mean, it looks like it's from the 1970s. Like a computer system that, you know, Steve Jobs would have been embarrassed about even back then. So yeah, there's definitely room for improvement in the user interface. There's definitely room for improvement in the mechanics of the device, but it's the only thing like it out there. It's the only thing you can place endoscopically and do during the procedure to figure out what's going on. So the numbers, flip distensibilities under 10 tight over, and that's what we're using for GPOEM case selection. All right. Any questions about that?
Yes, I have a question. In your experience, do you think that when you have media results from different investigations, and then you're doing endoflip and still maybe you have between 2 and 3 and for the esophageal junction, in your experience, do you think that the poem is successful for patients? Well, is when it's all like always in a gray area, and even the endoflip is not giving you a better answer, and then you're doing the poem.
So you're saying that all the investigations are gray, and then you do an endoflip to try and help you, and it's 2 to 3.
For example, yeah. First, are you doing the poem? Second, if you're doing your experience,
yeah, that's a good result or not. So the question you're asking has got a huge number of variables in the equation, I think, but because usually that doesn't happen. Usually you have 1 or 2 or 3 of the investigations point in the same direction, and if you have maybe only 1, you do the flip and you get it one way or the other. And my experience of achalasia is that they do really always have a flip result under 2. So that, for example, that patient we were discussing earlier, where the patient doesn't have symptoms and then their flip result is 2.7, 2.8, I'm not going to intervene on the LES of that patient because it's not, it's not in the range. The patient hasn't got symptoms, et cetera, et cetera. The patient got pain, but not dysphagia, et cetera, et cetera. So for me, there's always got to be a constellation of fitting the puzzle has to fit together rather than just a flip. And I don't recognize the situation very frequently where the flip is borderline in a situation where everything else is also borderline. It just doesn't happen to me very often in my experience. If that happened, then yeah, what is the choice? If the patient has significant symptoms in that situation, then as with everything in our job, when you get to a situation where the what to do is so gray, you then say to the patient, right, do you want to try for a solution for this? Here is the thing I suggest. It could make you worse. This might happen. It could make you better. This might happen. What do you think? And that's actually at the end of the day what it is, a conversation with a patient about if it's not clear. But I haven't had that situation very often. Normally the flip is very positive if the patient has got achalasia.
But when it's very positive, is there anything you will find then during the poem that, for example, the muscle are bigger or something? If it's extremely positive, is there something that correlates then with the difficulty of the poem?
Yeah, as usual, you're asking multiple questions at the same time, and then all of them are great questions. So let me try and unpick a little bit what you're saying. So Maria Eva asked me, is there some predictor from if the flip is very positive that you can see in the procedure, which means that you're that you can correlate one with the other? And she also asked me, does that mean the procedure is more difficult? Yeah, I think all those things are true.